All right. Well, hi everybody. Good morning. Thanks for having me come into the class this morning. So Gary, tell me how many people you said you've trained like how many classes? Like a dozen classes so far,
So
or how
this
many?
is the third official class that I'm teaching in this setting. After I
Okay.
did the Handtevy instructor course, we were offering it in the stations for me to go out and deliver it in station to different shifts, but we didn't get a whole lot of interest. So I think after today's class, I will have maybe around 60 of our 1,500 providers who have
Oh,
listened to me blab for 4 hours. But everyone who has sat and listened to me, with the exception of a few, have said what a value the course and the training is. So we're just, like I mentioned to you yesterday, we're trying to get more people engaged. A lot
yeah.
of what I'm hearing from providers is, I don't need to take your class because I know how to use an app. And I said, well, it's not just
Yeah.
about an app. It's about treating pediatric patients and taking stress level away and all of that other stuff.
Got it. Got it. Okay. All right. Well, so for those who don't know me, my name is Peter Antevy. I live in South Florida. I'm actually trained as a pediatric ER doc, trained in Pittsburgh, trained in California, and then I've been back in Florida since 2005. But when I came back to South Florida, my first, probably my first couple of months as like a real doctor back in '05, I made a tenfold medication error. I used to be embarrassed about that, but telling people that. But after training at two of the top 10 children's hospitals, you would expect to actually know what you're doing, and it turns out I didn't. And I kept wondering, why is it that someone like me is, you know, unable to run a code and know all the doses just like that, when in Pittsburgh and in Children's of LA, they seemingly knew how to do it. And I quickly learned that it wasn't just a me problem. In 2010, I became a medical director. The image you see behind me, that's the first department I've been affiliated with since 2010. And literally that same year I became medical director, we had a significant number of medication overdoses, midazolam, fentanyl. Even worse, were the patients who needed to get a medication, let's say they were seizing in the back of the ambulance, ETA to the hospital in 5 minutes, and that kid would not get anything. And when I asked my medic, why didn't you give anything? I would hear kind of a whole bunch of reasons. And that's kind of when I realized that doing math on the scene um, is not, is not something that anyone should ever do. So, I made the mistake. My medics were making the mistake of either giving a drug the wrong way or not giving it at all. And then I would find out that they were rushing onto the scene, grabbing the kid, a lot of anxiety. They had anxiety, the parents had anxiety. So they would just take the kid and rush off of the scene. So if you have found yourself doing that, which many of us have, then it turns out that there's a way of bringing your emotional anxiety level down before you get to the scene. And part of what we created this course to do is so that you can, en route to the call, let's say you have a 6 to 8 minute arrival time, you should be able to know exactly what to do for that kid if the kid's in cardiac arrest or having a seizure, um, before you get to the scene. That when you get to the scene, your heart rate is lower, you're not nervous, you don't look physically agitated, and then when you get to the scene, you can actually look at mom and dad in the eyes and say, "We're here to help," and actually treat that cardiac arrest on the scene. Um, I'm going to give you a story that happened in my department uh, probably 3 days ago. Um, my older son was graduating from high school at Nova Southeastern. It's a big college in the middle of my town. Um, I'm there till 2 o'clock in the afternoon. Literally, as soon as I leave, we get wind of a 9-year-old cardiac arrest. She was doing a dance rehearsal, and she passes out on the stage. Um, we get there within 6 minutes. A bystander had done CPR and shocked the girl once. Um, we have the ability of, um, I'm sure you guys have the same thing. You guys have Zols or Life Packs?
We have Zols.
Okay, so do you guys use case review?
Our
I think
data
Dan's shaking his head.
imported into, I'm sorry if I'm echoing, I'm trying to get the volume. Our data is imported into ESO, and then afterwards, our manager sends a case review of all the CPR data to whoever's on the call, so we can review like CCF, ventilations, compressions, all of that stuff.
Okay, all right, perfect. So you guys are I mean that's amazing to hear that you guys are doing that. So we get to the scene, and I'm going to I have the call up in front of me here. I just want to make sure I have all the numbers right, but we worked this girl for 35 minutes, okay? Basically right off of the stage. And if you look at her average compression rate was 110, her average ventilation rate per minute was 6. We actually had not one of the pauses was greater than 10 seconds, not one. Every 2 minutes they stopped to actually check a pulse, to check to check a rhythm. If I send you this kind of case review, well, we have life packs. It's called a code stat. If I show you this, and by the way, the girl was in asystole the entire time, so she's more than likely to have like a channelopathy or something like that. But when you can leave a code that almost an entire audience of people are watching you, and the parents are freaking out, and you can run a code where the case review looks like something that you could put in the Smithsonian Institute. Like literally, I told my guys yesterday, because I got them on a phone call. I said, I've never, ever seen a pediatric code run in that way. At the same agency, our survival, overall survival, I mean, again, it's not as big of an agency as you guys are. We only saw last year 64 cardiac arrests. It's about a count of about 110,000 people. And our neuro intact survival rate, all comers, it's 14%. National average is 8%. So once you go beyond this is an app and I have dosing, that's kind of like a very rudimentary way of thinking about it. The best way of thinking about it is, how do you feel before you get to the scene? Can you look at mom and dad in the eyes right when you get off your ambulance, and they're looking at you to think, does this person know what they're doing? And then can you stay on scene at least for the first 3 rounds of good, ALS care? Can you afterwards go up to the mom and dad and tell them everything that you did confidently, right? Without feeling like you didn't do a good job? Can you then go to the emergency department after you transfer care and talk to the parents again? So all that to say that, yeah, the dosing is important, but if you look at everything that we've done with the app, with CPR assist, checklist, protocols, and the fact that it integrates into your electronic medical record, hopefully you start to understand that it's not just about the dose of the medication, it's about how you're able to provide care to that kid or that adult, right? And so if I can share my screen real quick. Oh, Garrett, looks like you have to allow screen share. Looks like I'm not allowed to screen
Oh,
share.
hold on. Let me figure that out. Hold on.
All right. Yeah, just go to the on the very bottom, it says share screen, and there's a little arrow next to it. If you click on that arrow, it should say something like,
Oh yeah, there.
allow everyone, something like that. Okay, you got it. You got it. So if you're sitting here today, everything that you do, and you have amazing medical directors, I'm sure is evidence-based. So you want to make sure that what you're doing at your agency has evidence to it. And we've been doing this for 14 years now. There's 2,500 cities across America who use our software and our system. And I wanted to show you here a couple of those items because I think it's important. This is a study that was done in Denver. Um, Believe it or not, if you look at that green box on the right, they were making 50% error rate on pediatric medication dosing. If you go back in every single paper published in kids, every one of them, it's a 30 to 50% error rate. Just think about that. So in Denver, when they switched to us, they went to now it went from a 51% correct to 89.4% correct. Yesterday on the webinar, that's how Garrett and I connected. They launched Handtevy into a 12 system region up in northern New York. Their medication dosing rate for midazolam was 60% correct. They implemented Handtevy, and they haven't had a medication error for midazolam since June. They've had 100% correct dosing for midazolam, which is the drug that many people screw up. I'm actually here in Orlando because I'm speaking at Dr. Banerjee's conference. And the reason I come here every year, he published a paper back in 2019. They have about 38 to 50 cardiac arrests a year here in his town. Before they adopted our system, they had no survivors, not a one. When he published his paper, it went to 23% neuro intact survival. 23%. Okay. Those are children who would have been dead otherwise. So you can see here that here was the paper that they published, and then he's given me more data ever since. There's another 3 years of additional data he has sent to me, which is pretty incredible stuff. So I guess I'll stop the share there, but I guess I'll open it up for any questions, but what I wanted to say is that, I now work with over 3,000 paramedics. I'm a medical director for about 5 or 6 different agencies, medical director or associate medical director. I ride out on the street just like your medical directors do all the time. I realize how hard it is of the job that you have. I just offered to Garrett to come on today just to kind of say hello to everybody and just hopefully inspire you a little bit that the job that you guys do is very difficult. We recognize how difficult it is as medical directors, and we're just trying to make it a little easier and make the outcomes a little better. So I'll shut up there. I don't know if Dr. Dan, you want to make any comments, or Garrett, I'll throw it back to you.
Yeah, no, Peter, it's great. I'm so grateful for this product, and obviously you and I know each other well, and what you've been able to do has been remarkable. And I love passion projects in particular, and it's great to see passion turn into something so important. And I'll share a story from our side that then you can subsequently use as you see fit. We had a really, really difficult scenario a couple months ago. We had a fire with 2 young children trapped. This is of course the most challenging emotional scenario, with looking for both prolonged rescue and the odds that these kids were going to come out incredibly sick. And I was teaching interns, obviously dropped everything, headed to the scene with there. And the first thing, I had arrived well before we were able to enact the rescue due to the challenges of the situation. And I remember as we were standing up our medical group, the first thing I said was, all right, we have rough ideas of these kids' ages. We need 2 Handtevy drivers so that we can make sure, let's enter them in advance. We're going to, pull up that we got a 3-year-old and a 6-year-old and get the screens going. Because when they come out, we're going to be going out hot. And I want to make sure that we have every resource ready. I think of having that resource ready and being able to just, again, this is almost a position in your cardiac arrest, is just like you need a compressor, you need a ventilator, you need someone, and particularly with a kid, that was one of my assignments, is we need a Handtevy driver for each one of these, because we're going to need, this is going to come, and they did both come out in full cardiac arrest when they were rescued. And, again, the intensity of that, without having those references, dosing a cyano kit off the top of your head on a lawn on a
No.
little one would be impossible without this tool.
Yeah. Well, Dan, thank you so much for mentioning that. I will tell you that in that particular case, if that if those kids were just transported and nothing was done, and let's say they had a bad outcome, what it turns out to be is that if you're the paramedic on that call, your brain doesn't let you forget that you didn't do anything. You know what I'm saying? You can't trick your brain to say, you know what, that kid needed an airway, the kid needed cyanotape, the kid needed all these things, and I didn't do it. You can't really explain that one to yourself away. And what I've learned, and you've probably seen the same thing, but as you get older in the job and you've seen more and more and more, you can't tell your brain that I shouldn't have done that, or it was okay what I did, because the brain doesn't let you forget, right? And so I don't know about you guys, we've had over the years, over my 14 years in EMS, we've had a number of suicides in EMS from my own folks. And so I've been to too many funerals, and these were men and women who were, it looked like they were doing great. And then suddenly they just, you know, decide to either do whatever they did to themselves without giving the detail. And so for me as a medical director, this is so important that we kind of at least do what we would do if it was our own kid, if it was our friend's kid, that we as EMS should be doing that on the scene. And those kids who came out of a fire, we should be treating them, at least giving them the best chance to live right there. So I love what you guys do, that you actually have someone, if you have enough people, have that extra person drive it. And I have a lot of videos of that where we have one of our officers, or it could be battalion chief, it could be a captain, at the scene. He's got CPR assist open, all the dosing is being called out. And when you look at the cardiac arrest being run, like on that, in that school a couple of days ago, you had the sense that we were not leaving, right? And that's the kind of feeling that it does take time for people to get to that point, but all it takes is one call, and you feel that feeling, and then it's game on, and then the next one gets better. So Garrett, what I would say to you is, you've only trained up 60 people. You have a lot more to go, but for the people in the class, if you go through the class and you think it was horrible, well, then you should say something as to why it wasn't good. But if you go through the class and you think it was great, and you actually are using it on a scene, then you should tell the other people in your department, and that's how hopefully more and more people will start to do it. At my agency and agencies around the country, people just use this course as a routine course that the entire department takes, and that's when you start to get a shift of mindset of, okay, this is how we're going to do things now. It's easier for me, it's better for the patient, and hopefully outcomes will get better. Nice to meet everybody, and I hope that you join the class. Thank you.
Thank you so much. Your check's in the mail.
How was that?
Anybody else want to say or ask Dr. Antevy? He's like a brilliant mind sitting in front of you right now that I was able to negotiate to be here. So speak now, forever hold your peace. No. Doctor, thank you so much for taking time out of your day. I know you've got a lot of other things going on, so it's always nice to chat with you, and we'll be in touch later.
And Garrett, I'm happy to jump in anytime. And Zoom is easy for me. I can do it I can do it like Dan when I'm driving, safely.
Oh, yeah.
But yeah, so I mean, I'm happy to do it. Whatever it takes, I'll be there for you guys.
I appreciate it. Don't worry. I got your cell phone number and I got both your emails, so we'll be in touch.
Be careful. Garrett calls me not infrequently. So you've opened a little bit of a Pandora's box. But Peter, it's great to see you. Thank you, my friend.
Thanks, Dan. I'll see you at NAMSP.
Absolutely. All right, brother. Take care.
Okay, you got it. Bye, guys. Stay safe out there.